Good afternoon and welcome to the second part of the presentation. The CCR will be presented by Surgery Department of Surgical Gastroenterology. I welcome you all. Congratulations, gastroenteromedicine people. You have made a very difficult case look simple to understand. Ours is just the different. Ours is a simple case. We may make it difficult to understand. So this is a patient which we managed, which we started managing 2 years back, but the management completed the entire course of management completed only a few days back. So, without going into much details, I would request Dr. Sunil to present the case, and then as we go on, the other departments will be participating in that.
Good afternoon, faculty and dear colleagues. Our patient is a 38-year-old female housewife from Delhi. She presented to gastroenterology department in July 2018 and she remained in follow-up till February 2019. She presented with complaints of mild upper abdominal pain for 2 years. The pain was of non-specific nature, non-radiating and not related to food intake, and at times associated with the vomiting. The patient got relieved with the intake of proton pump inhibitors and antiemetics. So she was on PPI on and off. There was no history of loss of weight, loss of appetite, weakness, jaundice, and GI bleed. In the past 10 years back in March 2009, the patient presented to ophthalmology department, AIIMS, with complaints of intermittent blurring of vision in the right eye. She was investigated and her MRI head and PET scan was suggestive of mass at the origin of optic nerve. And she underwent removal of the eyeball and the prosthesis placement. The resected specimen of the eye shows malignant melanoma choroid infiltrating the optic nerve. So, in view of the disease confined to the eye only, she received no adjuvant therapy. Follow-up PET scan 6 months later in October 2009 shows no evidence of active disease. She underwent minor surgical procedure of right breast fibroadenoma excision in 2018. She was a non-case of bronchial asthma with exacerbations. She was diagnosed as a case of Graves' disease in 2013, but at the time when she presented to us, she was euthyroid and off medications. In her family history, no family member is having any history of chronic illness. She was vegetarian and having no substance abuse or drug addiction. On physical examination, uh, she was of average body build with good performance status and vital stable. There was no pallor, no icterus, no lymphadenopathy, sinuses, clubbing, and generalized lymphadenopathy. She was having a prosthesis in the right eye. Her chest was clear and heart sounds were normal. Her abdomen was flat and there is no tenderness, organomegaly, palpable lump, or fluid thrill. Her bowel sounds are normal. Her pervaginal and perrectal examination are largely unremarkable. So from the history and clinical examination, she was thought to have problem of upper GI tract or hepatopancreatobiliary system. And the commonest investigation done in this situation are ultrasound and upper GI endoscopy. Upper GI endoscopy was normal and ultrasound shows non-specific lesion in the head of the pancreas. So she was further investigated with cross-sectional imaging for characterization of the mass lesion. Now I would like to invite Dr. Anisha from radiology.
This patient underwent multi-phase CCT of the abdomen and pelvis on 29th of August 2018. The first row shows the non-contrast axial images of the abdomen. Here we see that there is an ill-defined lesion in the head and proximal body of pancreas, which appears hyperdense on the non-contrast phase. A similar lesion is also seen anterior to the duodenum and uncinate process. This could be a peripancreatic node that is involved by the lesion. Next, we have the arterial phase and the venous phase contrast images. This lesion does not show any significant contrast enhancement. And we find that in segment 6 of liver, there is again a hypodense hypovascular lesion. Uh, A CE MRI was done for this patient on 14th of December 2018. This is the opposed face T1 weighted axial image. Here, this lesion in the head of pancreas shows T1 hyperintensity, suggesting some hemorrhagic or proteinaceous component within the lesion. These are the T2 weighted images, which show mixed signal intensity of the lesion with areas of T2 hypointensity and hyperintensity. The liver lesion is predominantly T2 hypointense. These are the arterial phase images, arterial phase contrast enhanced images, followed by the subtraction images. Here we find again the lesion shows no significant contrast enhancement. A follow-up MRI was done after 9 months on 16th of August 2019. These are the axial T1 weighted and the T2 weighted images. Here we find again the lesion shows T1 hyperintensity along the periphery with the T2 hypointensity. And the lesions have increased in size as compared to the previous scan, though no new lesion was seen in this present scan. So, summarizing my findings, we have multifocal lesions involving the head of pancreas, the peripancreatic nodes, as well as in segment 6 of liver, which show T1 hyperintensity and hyperdensity on the non-contrast phase. So for such multifocal lesions, the possibility would be of a neoplasm containing some hemorrhagic residue, like neuroendocrine tumor of the pancreas with the metastasis to the peripancreatic nodes and the liver. A rare possibility could be of a pseudo-papillary neoplasm of pancreas, which can also show hemorrhage sometimes. And since the patient has a history of choroidal melanoma, so a possibility of metastasis also needs to be considered, though pancreatic metastases are relatively rare. Thank you.
Yes, endoscopic ultrasound is the best investigation. Really need the pancreatic masses. The patient underwent endoscopic ultrasound in December 2018. That was suggestive of a solid cystic hypoechoic 3 centimeter mass at the junction of head and neck of the pancreas, as shown in the figure. That was suggestive of a neuroendocrine tumor or a pseudopapillary neoplasm of pancreas. So to further characterize the neuroendocrine tumor and to rule out the metastasis, she underwent Dotanox scan on February 2019. Somatostatin receptor expressing two heterodense lesion of the size 2 centimeter and 3 centimeter in the head of and neck of pancreas was found, and a calcified granuloma seen in the segment 6 of the liver. As shown in the figure, we can see that the liver is having normal uptake, liver and kidney, and there are 2 pancreatic lesions. And it is suggestive of likely multifocal primary NAT. You also have had serum chromogranin done that was normal. With this workup and a referral diagnosis of multifocal NET or solid papillary neoplasm of pancreatic head, she was referred to GI surgery in February 2019 for possible surgical intervention. The patient lost to the follow-up till July 2019. She was admitted to GI surgery in August 2019. She was again evaluated and investigated, and her symptomatology and clinical profile largely remains unchanged. And since there is a gap of 7 months, so MRI was repeated again, and as told by Dr. Anisha that the MRI shows an increase in the size of the mass in the head of the pancreas, and rest of the radiological findings are similar. She was planned for surgery with a diagnosis of neuroendocrine tumor or solid papillary neoplasm, head of pancreas, with a plan of intraoperative assessment with ultrasound and sampling of the liver lesion, followed by pancreatic duodenectomy resection. I'd like to invite Dr.
So, actually, honestly, prior to we took over the case for surgery, the diagnosis was never ever thought of as a secondary to melanoma because of some reasons we will discuss. It was always either NET or a SPEN. So With that, the best management is surgery. We took up the patient for surgery, and on laparotomy, uh, this was a sketch presentation of this. This is possibly the tumor, and this was the suspicious lesion in the liver. So after opening, the first thing we found is this is the colon one, and these black nodules, possibly the lymph nodes. And then, as planned, we tried to dissect the tumor, the pancreas, the tumor, and tumor, along with these masses, were actually had infiltrated the mesocolon. So we thought that this is when we really started thinking that could be a melanoma that is having a metastasis, pancreas or lymph node. So it was very rare. And after dissecting this one and then taking down the colon, the tumor we have dissected out, and these are the lymph nodes. While taking out the lymph nodes, they just broke like chalky material and spread all over the area. And then after that, the protocol or the steps were absolutely difficult to conduct because it obscured the entire anatomy. So we tried to take the tissue in a different manner, starting from here and then ending up into the pancreas and finally taking out the pancreas. That's why it took a lot of time to us to complete the surgery, about 8 hours. The basic surgery that was done is we have taken this much of the tissue or the organs, the head of the pancreas, the duodenum, bile duct, lymph nodes, the entire thing, and part of the transverse colon and mesocolon. And they did the reconstructions as and when to pancreas to jejunum, jejunum to common bile duct, to stomach, and a feeding jejunostomy. This is what the final picture is. This is the jejunal limb, anastomosis, is by biliary anastomosis. This is the specimen, the transverse colon and duodenum with the pancreas in its C groove. Uh, Post-operatively, the patient had a mild pancreatic anastomotic leak, and that was managed conservatively. These people, after extensive dissection because of neuronal damage or collection, they went into a delayed gastric emptying, which is a very common complication of this procedure. This is CT scan which shows collection behind the anastomosis. It was trained percutaneously in the radiology department, and she had also minor surgical site infection. And finally, without any problems, further problems, she was discharged on post-operative day 20. We had the histopathology just by the pathology department.
We had received multiple issues for frozen, and all of them showed viable tumor, which shows this coarse brownish black granular pigment in the cytoplasm, which fits the classic description of melanin. The tumor cells had abundant melanin deposition in them. They had moderate to abundant histopatholic cytoplasm with pleomorphic nuclei and very prominent nucleoli, as we can see here. The cells were immunopositive for HMP45, which shows diffuse cytoplasmic positivity, as we can see in this picture. And there was a tissue which was sent as pancreatic tissue near saponification, which showed fat necrosis. No viable tumor cells were seen in there. There was a liver SOL also, which showed only a fibrotic capsule which separates it from the liver parenchyma adjacent. And there was a streak of dystrophic calcification along with areas of melanin pigment deposition. Coming to the resection specimen which we received, we could identify the two tumors as seen here. This was one foci and this was the other one. Cut section showed this grayish white tumor with evident black areas as seen here, which on microscopy again showed the same similar features as we saw in the frozen. This is a tumor with adjacent normal pancreatic parenchyma. Here the lobules of the pancreas are visible, and here is the tumor with the melanin deposition. Again, the same histomorphology as we saw in the frozen sample with melanin deposition. Here, the tumor was reaching close to the adjacent bowel wall, but it was not infiltrating into it. There were 6 lymph nodes which we could identify from the specimen, out of which 1 was involved by the tumor, and the pancreatic neck resected margin was involved by the tumor. As we can see here, the tumor is reaching up to the pancreatic neck margin. Based on all this, a diagnosis of metastatic malignant melanoma was made.
Two interesting things here in histopathology. When we sent the liver nodule, that was looking black, but the histopathology, the frozen section, there was no tumor cells, melanin pigments were there. Same thing happened to most of the lymph nodes. Many of them, only 1 came positive, all others were black. When we reviewed the literature, we found that metastasis to liver and lymph nodes in melanoma, they can be self-regressive. Might be one of those cases. I think they can undergo remission on themselves without in management.
In follow-up, her feeding jejunostomy tube and pancreatic stent were removed at 6 weeks. She underwent stent cholangiogram at 6 weeks. It was found to be normal, as shown in the cholangiogram X-ray. There is a free flow of contrast from the bile duct into the jejunum. So the stent was removed after 6 weeks, and the patient was sent to the IRCH for further adjuvant therapy. Presently, after a follow-up of 24 months, she is doing well. She received further treatment. She is tolerating, and last cycle she has received on 20th of October 2021. Now I would like to invite Dr. Sameer Rastogi sir from Medical Oncology.
Good afternoon, everyone. So when the patient came to us after 3 months in December 2019, patient had metastasis to liver. That lesion was enlarging lymph nodes and bone. And since 2011 onwards, we have immunotherapies available. So we started patient on anti-PD-1 therapy. How these checkpoint inhibitors work is that this is PD1 on immune cells, and this is PDL1 on tumor cells, and they are negative regulators of immune system. And after approval of pembrolizumab, which is checkpoint inhibitor, the overall survival for metastatic melanoma is almost 3 years, median overall survival, with response rates of almost 1/3 of people do respond. Previously, there was hardly survival beyond 1 year. So we enrolled patient in Keynote 593 trial, which is going on in our institute. Patient gave consent, and she had liver, mediastinal lymph nodes, and vertebral metastasis. Her LDH was normal, and since melanoma has high propensity of brain metastasis, brain MRI was normal. So she was started on injection pembrolizumab, which is PD1 inhibitor, starting from December 2019. And this is the liver lesion which has become larger, and this is in 2019 before the start of immunotherapy, and this is in 2021. This has shrunk. Similarly, the mediastinal nodes and these nodes, this is in 2019, and this is after 2 years of immunotherapy. So patient is currently being continued on immunotherapy and has partial response by RECIST. And of course, it is immunotherapy. So patient has 2 toxicities, which are autoimmune toxicities, vitiligo grade 1 and hypothyroidism grade 2. However, there is no hair loss and there is no other chemotoxicity. So she will probably complete 35 cycles of immunotherapy, and then we'll keep her in follow-up. I'll again call Dr. Sunil for further discussion.
Melanoma metastatic to GI tract was first described in 1931, and it usually affects the multiple sites and rarely presents with solitary metastasis. The metastasis to pancreas only is extremely rare and is seen in less than 1% of metastatic melanomas. Till now, 76 cases are reported, and the most common site for primary is skin, followed by the eye and nasal cavity. Melanoma of eye metastatic to pancreas. Till now, only 10 cases are reported. So, table showing the cases presented so far with isolated pancreatic metastasis. We can see that the duration between the primary tumor excision and the appearance of the metastasis ranges from 3 years to 28 years. And the survival at the time of follow-up ranges from 6 months to 2 years. The treatment of metastatic melanoma is multimodal and palliative. It includes surgery, chemotherapy, immunotherapy, and a combination of these. The experience with the surgery is limited and controversial, and it should be done with a curative intent only. As the studies have shown that incomplete resection patients are having survival no better than non-operative patients. The survival directly correlates to the primary site of the origin of the melanoma, and only complete resection improves the survival. A study by Wood et al. Shown that the complete resection of metastatic melanoma to solid organs leads to a statistically significant increase in the median survival as well as the 5-year survival in the operative group compared to the non-operative group, as well as also the patients undergoing curative resections are also having statistically significant median and 5-year survival as compared to the patient who undergone palliative resections. Metastatic melanoma has a poor prognosis. The prognosis of malignant melanoma metastatic to pancreas is difficult to ascertain, as only 10 cases have been reported so far, but is probably poor. The various factors that are favorable are a metastasis from the primary, that is of ocular origin, and a long latency period between the primary tumor and the appearance of the metastasis, and complete surgical resection of the metastasis. And metastasis to the pancreas is having a favorable prognosis compared to the liver mets as well as the lung metastasis. However, no obvious correlation was seen between the tumor location in the pancreas and the survival. So, to conclude, late occurrence of pancreatic metastasis from ocular melanoma is very rare but carries a good prognosis. Long-term follow-up is required. Metastasis can closely mimic common pancreatic tumors. Surgery with curative intent is the treatment of choice in resectable tumors. The diagnosis must be suspected in a case of a patient with a history of treatment for melanoma of other site, even though of the long duration. Complete metastatic workup should be done prior to start the surgical therapy, and the newer immunotherapeutic agents are likely to increase survival in future. Thank you. Any questions?
Thank you, all of you. There was also constant involvement for the departments, gastroenterology and anesthesia and other departments for the period. So I thank all of them. Now the liver lesion was about a centimeter size. It was black in color. It was resected and sent for frozen section. It didn't show in tumor tissue. One thing is what Dr. Samir said, that the liver lesion was subsided. Maybe we had taken out the tissue, taken out the tumor, and then there was a gap there. Whether over a period that has subsided, I can't tell. But looking at the mediastinal things and a tumor recurring there, little bit. No, no, it was a for biopsy purpose. That way, that point is correct. Maybe a recurrence. Yeah, but there were no tissue at all.
Dr. Dash, nice case. Why was Dotonox positive? Why do you think? Like, how do you explain it retrospectively?
Sir, in many cases of melanoma, there are.
He asked. But why Dotanac scan was positive? Oh, that I can't answer really, honestly, because
Sir, it was seen in the literature that many cases of malignant melanoma metastasis are having somatostatin receptors. So probably could be due to that the Dotanac scan came out to be positive. Yes, sir. The Dotanox scan was done because on in cross-sectional imaging we suspected to be a neuroendocrine tumor with cystic changes. So we, yes, yes,
yeah,
sir.
we saw in the literature that they take up. But I said I can't explain. Actually, we also can't explain exactly when chromogranin is negative. How can that?
I'm just saying if Dotanoc is positive, then chromogranin should have been high. So that was the other reason.
Yes.
Sir, could we have done a US guided FNAC or a biopsy?
Now, as he presented the gold standard of diagnosis for a pancreatic melanoma, there is no case of primary pancreatic melanoma described yet. To diagnose the secondary deposits in the pancreas, the gold standard is US guided FNAC. Had we any suspicion earlier on prior to this, we would have certainly done it. How it would have made a difference to the management? NAT or papillary tumor of the pancreas, you can wait for some time for management. But here we need a definitely management as early as possible. So there it makes a difference to do a US guided FNAC.
But Dr. Dash, you had lymph nodes which were there, mediastinal lymph nodes. In 2019 CT, the lymph nodes were shown by Dr. Sameer when they regressed subsequently.
We are not done a CT of the chest.
So earlier, if a PET CT did not pick up the lymph nodes and the lymph nodes were not there, then that could have made a case for US guided.
But we did a Dotanac that might have that should have shown us.
And secondly, your CT had shown multiple lymph nodes. So if you have multiple lymph nodes and a NAT and a liver lesion preoperatively, then there is a case for EUS guided biopsy. If there was only one single pancreatic lesion, then yes, I agree with you that EUS guided FNAC may not have a role.
Secondaries may be seen many years later. So
Yes,
that
that
should
3
have
to
been
3
kept
to
in
28
mind
years.
somewhere. Somewhere it should have been in the mind of one of the physicians that it is possible that this is a melanoma.
Yeah.
If you know that this is a metastasis from
I
melanoma,
agree. We should have kept it in mind at the time of diagnosis.
if you know prior that it is metastasis from the melanoma, does it changes your management?
No, because literature clearly says that in these cases, if you do a surgery, survival is significantly better.
I have another question. It is more generalized to Dr. Sameer. Why some tumors have a very lag period? They have treated, they have very long gap, like malignant melanoma and also in RCC. You see, they 20 years, 30 years, they are perfectly fine after they have a metastasis. This is the reason for that.
Regarding this patient, it is not behaving like typical melanoma. Melanoma is supposed to be too aggressive. I think 2018 imaging was done and 2019 imaging was done. There was not a there was no market progression or metastasis to elsewhere. So, but we don't know. It might be interplay of immunity. It might be tumor cells. It might be a lot of things going on because these are tumors which are sensitive to immune system. So this interplay is difficult to define.
Although most people don't believe that, there are people who say that we have seen it. And the mechanism is believed to be the immune response. That's why they tend to recur much later when there is some change in the immune status. And again, this is all hypothesis. There is no evidence to support it, but the dots kind of fit again. that these are immune responsive tumors and variations in immunity may be associated with their recurrences much later. And the same thing happens in melanoma and the RCC. That's why PD-L1 that they use here is a standard therapy now for metastatic RCC. Although I'm surprised that we managed to use it for 35 months, very long period of time for pembrolizumab.